Good afternoon, everyone. I'm Ria Anandwala, Director of Communications with the Consumer Technology Association. Welcome to our session, AI in Healthcare Solutions Beyond the Buzz, part of CTA's Technology and Standards Spring Forum. We're very glad you could join us today. AI has changed the landscape of consumer interaction and business operations across industries, from manufacturing to agriculture and health. In the past few years, artificial intelligence has emerged as a favorite buzzword. It's front and center for many businesses, and without AI, any discussion about the present and future of tech is incomplete. Here at the Consumer Technology Association, we do a great amount of work in the digital health space, specifically AI. Last year, we started a working group on AI and health that now comprises more than 50 companies. And this year, we published the first ever standard on the use of AI in healthcare, which sets a foundation for implementing medical and healthcare solutions built on AI. In the recent weeks, AI has gained a lot more attention for monitoring, triaging, and potentially treating COVID-19 patients. In today's session, our three experts from the healthcare technology sector will take us beyond the buzz around AI and delve deeper into how it is playing a significant role in improving health outcomes. We will start by sharing the speakers' remarks and discussion, which we recorded earlier. All of our speakers are live with us today, and they will be answering your questions after the panel discussion. To submit a question to our speakers, click on the icon with the speech bubble in the toolbar at the bottom of your screen. Feel free to submit your questions at any time during the session. And with that, I would now like to introduce our speakers for today. Nicola Kammath, Head of Product Marketing at Ginger, an on-demand mental health company. Tony Reina, Chief AI Architect for Health and Life Sciences at Intel Corporation. And Simon McGibbon, CEO and co-founder of Maya Health, a learning system that augments clinical care for patients beyond the hospital. Thank you so much for joining us. So to start a conversation today, I would like to ask each of you to talk about the use cases and implementation of AI in your individual companies. Nicola, how about we start with you?
Thanks, Ria. It's awesome to be here today with this group and talk about something really important and relevant in our world today. So I'll start with just some brief remarks on how we use AI at Ginger. So I think, when we think about technology helping an industry, it's first important to understand what is the problem that we're solving for. At Ginger, we're an on-demand mental health system, and we're solving a mental health issue. The workforce is struggling across the board. 1 in 5 Americans experience a mental health condition, but more than that, 83% of employees are just stressed on a regular basis, and it's impacting them across the board. 50% of them missed 1 or more days of work due to this stress and just due to the impact of mental health on their life. I love a visual representation. You can just see here, this is a map of the United States mapped out by county. The dark blue is where there are mental health shortage areas. We have a massive supply and demand imbalance in mental health in America. Folks just can't get the help they need because there aren't the providers available for them to walk into a therapist's office. And, this is where really technology comes in. Scaling quality, it's not just about giving access, but it's really about scaling quality remains a challenge. We know that 70% of folks are not getting effective mental health care. We talk about things like minimum standards and quality measures, technology-based resources and having standardization there, and then just a lack of kind of support and training for mental health professionals. So it's a really interesting thought of the problem. It's not just the access, but it's also scaled quality. And so there are existing approaches in market, but we really think about that problem really deeply about how do you scale quality care. So a little bit about Ginger before we talk about how we use AI. We're a mental health system. That means that we offer coaching, therapy and psychiatry, and clinically validated content. So someone downloads our app, and within a minute, they're texting with a coach. within our Ginger platform. That coach works with them on their needs. They're trained, and as we'll talk further, we have AI running in the background of 100% of those coach chats. If someone needs more help, they bring a therapist or psychiatrist into the care team, and collaboratively, this care team addresses the needs of the member, all virtually. So this is a bit of how our virtual health system works. And it's really on this premise of access for everyone, a new quality standard, and just achieving global scale through technology and AI. So now I'll kind of dive into a bit about our technology and about how we use it in real life. So we have started on just a big data set. You can see a bunch of numbers on here. We screened hundreds and hundreds, over 600,000 consumers, collected 3.2 billion data samples from these conversation logs I mentioned, and many records on therapy and psychiatry surveys and outcomes. So we just started with a lot of data, and then we worked on with hospital and healthcare systems. So you can see we have a bunch of patents, publications, validations, and research studies on here that we've done to learn and build a technology database. And then we've put it to work. So I know this is the part everyone kind of wants to know. Like, great, you've got a bunch of technology. Great, you've spent 8 years building it. What do you use it for? So I think the interesting thing is we think about the problem of access and scale. Without a doubt, bringing care virtually through a single platform helps with access. Putting technology behind these coaches and clinicians supercharges them and allows us to offer it immediately and scale high quality interactions. And here's how we do that. We take a bunch of input. So you see on the left there, I have data we get from chat transcripts, clinical assessments. Members are giving us feedback and satisfaction data. We have, and then we have passive data we're collecting. We know how long sessions are. We know what's mentioned. We have notes between providers. So we take all this data and then we transform it to be able to inform who needs support, what do they need, and is it the right decision? So here's an example, scaling our provider operations. So we use one tangible way we use AI is for workflow management. So we have all this data coming in, and through it, we can give our providers smart information about how to triage, who needs a higher level of care, when do they need it, and they'll see this information coming through on our coach portals and in our proprietary hubs. We'll also use that information to inform care plans and goals. And finally, using our AI, we'll be able to inform the care team when is a good time to proactively outreach. So by using technology to support our care team, we can enable better workflow management throughout our care system. The second way that we use AI that I think is really impactful is just improving care quality. So on the left there, I've thrown in a visual of what the chat looks like. I find that that's always useful to put a face to like the member experience. On the back end, we have NLP across 100% of these chats. So you can think about safety risk escalations. If there's mentions, you can think about just escalations of care. And you can also think about unprecedented quality measurement. And what I mean by that is using NLP, we can even pull out, I'll give an example, therapeutic alliance. We know it's really important for a coach to have strong rapport with the person seeking mental health care. Our NLP can pick up on elements of that conversation to indicate, are there signals that they're building a relationship? So that's just one example of ways that we can do that. But we have a variety of quality attributes we're now able to measure because of this on the back end. And we use that, I should say, and how we use that is really interesting because we also feed that back into clinical rounds. We feed that back into the clinician's workflow so that we're not just automating workflows, but we're making sure to improve the quality. So this is kind of the impact of using this technology to scale our care. First of all, immediacy. Through this streamlining of work and lifting the burden off our providers, we're able to offer a median of 44 seconds to connect to a coach, 24/7, because of the scaled way we use AI, as well as our care model. And also 10.5 hours to reach a therapist. So if we go back to that problem we're trying to solve, you can really see how technology helps us superpower and address that access issue, as well as the care, as well as the quality. Across our system, 70% of folks see an improvement and are feeling better. We also do another kind of measurement where it's looking at how does the member actually feel after each session. The first part is clinical outcomes to make sure that we're impacting their depression. The second is how do they rate us out of 5 stars on the experience? And that's an important feedback when we think about quality and care, is does the member feel better? And so we see that across all our sessions for coaching and therapy and psychiatry, that there's a 4.7 out of 5-star rating, which helps us understand, is the technology actually working?
Thank you so much, Nicola, for that insightful presentation. Simon, would love to hear more about Maya Health.
Yeah, thank you very much. It's a real pleasure to be here, and I think it's a fantastic idea to be organizing a session like this. So thank you very much for the opportunity. We're going to talk to you a little bit about how we use AI or machine learning in particular here to power virtual care, and basically virtual care being a sort of extension of the ability to take care of patients from the home and not require them to be coming to a facility for their care needs, at least every time. Maya is a learning platform, specifically a virtual care platform that augments clinicians' ability to take care of patients from the hospital. We do that by capturing this high-dimensional data set from the edge, as we say, or the home, being a part of patients' everyday lives. We capture information such as physiology, self-reported patient symptoms, activity, sleep, which sort of is representative of a broader set of functional markers as to what's going on in the patient's lives. Many of these functional markers are often collinear or predictive, along with some of the physiology. We need to understand the environment that the patient is in. This could be everything from social determinant sort of context, as well as weather, sometimes depending on the condition as well. And an understanding of their community. Do they live alone? Do they have family nearby? Do they have access to transport, etc.? We bring all that data together and get it out of the home with a backhauled either through cellular data network or the patient's own broadband if they happen to have that. It's important to be able to support both modalities. We use machine learning both to make sense of the data and turn it into actionable insights for clinicians, but also to structure it and address quality issues. And we have a lot of data coming from the edge. It's subject to contamination in terms of understanding the context that the patient was in when you received that piece of information, for example. So there's sort of a heavy set of computational processes on the back end before it gets to the clinical workspace, as we call it. Now, the clinical workspace is where the clinicians receive the information or the actionable pieces of information, where we sort of orchestrate workflow and facilitate the right level of clinical responsibility or team member to take action on the information. And that clinical workspace integrates with the EHR of choice for a respective hospital system. It's really an end-to-end system that allows care management for patients from the home. Example application of this is one of our key customers who in 2015 launched the country's first virtual hospital. But literally, this is a hospital without beds, if you like. Within this facility that was created by Mercy Health, which they call Mercy Virtual, there's programs such as EICU, but also a chronic care program where you literally have teams of coordinators, nurses, advanced practitioners, and physicians working together to keep people healthy and stable and out of the facility in an effort to improve health outcomes at the right cost for the health system. Here's an example of a nurse in action, in an encounter, a virtual encounter with a patient in the home. I thought, after explaining what we do, it might be worth going into a little bit more detail as to the context and the approach behind this from a machine learning perspective. First of all, I use this image to depict the fact that patients live in all kinds of circumstances, a variety of socioeconomic situations, a variety of rural versus metropolitan geographies. And the first step for us before we can even be intelligent with the information is to get the information out of the home reliably. So in this case, we use an IoT router that's paired to a hub. The devices that we send to get data on a daily basis connected to the system, and allows us to get the data into our backend in a very reliable fashion, regardless of where someone lives. In terms of our approach to machine learning, or AI in this case, we are effectively a clinical decision support system, or from FDA parlance, a non-device clinical decision support system. And I will break down a few of the elements behind the scenes here that go into this. The first is sort of input, capture, and quality. So this is getting the data from the edge or the home, the extent to which it's passive, the extent to which we can avoid contextual contamination, really by that meaning controlling the context when we get the data, which allows us to more confidently derive meaning from it. An example might be some of the pitfalls of getting wearable data, or let's say data at points in time during the day, is what the patient might have been doing before that measurement was taken. They might have been walking up the stairs, they might have come in from the garden, or they might have been watching Netflix. And so if we're unaware of the context or unable to control the context, we could misinterpret or ascribe the wrong value or meaning to a discrete piece of information. Of course, there's the endpoint capture, and this is pretty much everything for a machine learning or intelligent data-driven platform in healthcare. So this includes, let's say, the hard health outcomes, such as unplanned hospital admissions or emergency room visits. It includes mortality, of course. But also, we're very interested in other endpoints which, let's say, help us predict what is the optimal time for a provider or a healthcare provider or clinician to be in the loop, and when does a human need to be brought into this assistant relationship with the patient. One of the challenges in virtual care is that it works through some phenomenal outcomes that our customers have achieved even before we were on the scene. But you're effectively providing more continuous care, and therefore it's quite resource intensive. So machine learning becomes important to know, okay, what's the right level of care for the right patient at the right time that allows this health system to be able to do this scalably. The next part of this engine, if you like, is a Gaussian process engine, and this is where we can intelligently manage a data set with variable sample rates, for instance. There's a difference between getting blood pressure once a day from a 200 hertz ECG sensor, or some measurements the patient might be giving sporadically. Some measurements are received every day, and so it's important to be able to structure the data in such a way that it can be then ingested by a predictive model. This is really about preparation and management of this data set before intelligence can be applied to it. We have a proprietary event, what we call a general event model, or the GEM, and this is effectively a efficient probabilistic inference model. And this allows for the benefits of such an approach here allows for estimates of confidence in the predictions, for instance, and of course near real-time updates. The ability to not just have a prediction but have your confidence in that prediction is quite important, we believe, when it comes to transparency. So, for instance, this last point here, clinician transparency, it's essential as a clinical decision support platform to be able to give clinicians the ability to independently evaluate the basis of a decision. And so everything needs to knit together coherently, as well as the fact that we cannot have this be a black box. We need to be able to basically back out of the recommendation and be able to display the underlying drivers of it. And actually, before I move off this page, I'd probably skip one of the more important points related to fairness constraints. So crucial in healthcare, in many settings where humans are involved, that we design in fairness constraints, so a model cannot basically unfairly optimize on some dimensions. Of course, you can't operate in healthcare without being buttoned up and really understanding where you sit as a business in the regulatory framework. This is just meant to represent this as the overall idea. As I said, we are specifically a non-device clinical decision support software, but certain other algorithms are required to go through 510K approval as a software, as a medical device. Needless to say, essential that your business understands this in great depth. And we're actually quite impressed with, in general, the direction and the guidelines the FDA has laid out for the domain of AI machine learning. Finally, you could have the best models in the world, and they would be all for nothing if clinicians are unable to use the data, or it gets in the way of providing clinical care. Really, our goal is to have the technology to be in the background. This is a quote from one of our own test community patients that sort of says it all. So, while we're introducing a lot of promise and potential with intelligent software, it's in context of it being a fair problematic landscape with respect to the adoption of technology in healthcare, and how much, for instance, EHR systems have sucked a lot of the clinical time away from, or a lot of the patient time away from that clinician's daily routine. We have to be extremely mindful of that. And finally, this is near and dear to our heart. We do believe that we are in the business of trust, both trust with patients and with clinicians as well. And this runs the gamut of transparency, interpretability of model outputs, as I said, fairness constraints with respect to mitigating any model bias. We believe estimates of confidence around predictions are important, rather than sort of some definitive declaration that the machine has the perfect answer. There is no such thing. And fail-safe designs. And we, of course, ultimately believe technology should also be doing no harm. If you are interested in a sort of deeper perspective on this, you could go to STAT and search on Dr. Tom Maddox or my name, Simon McGibbon. And we posted out a piece last year about this, sort of really a bit of a call to action for all of health tech. Finally, a little bit of reflection on COVID and the way we view it. I mean, it's obviously a tragic situation that has probably driven about 10 years of adoption in 7 or 8 weeks. So there is perhaps a silver lining at the end of this where aspects of convenience will really become mainstream. And this will be, we believe, beneficial to patients and outcomes and clinicians too. However, we do see that making the shift it cannot just be about the virtualization of an encounter or visit, and that there's a broader transformation that has to happen for this to really produce better outcomes, and to make it scalable for health systems to make this transformation to providing virtual care. Machine learning is a huge component of this with respect to being able to identify temporal risk of patients. It's not enough to say who in your patient panel is risky, but you sort of need to know when they are risky. So there's this temporal aspect to it. The ability to automate some of the grunt work so clinicians can operate top of license, for instance. And we do see a lot of opportunity to use asynchronous communication as well. So you're not just sort of virtualizing the serial slowing of clinical time, but able, especially for those patients that gravitate to it, be more efficient and effective by using asynchronous methods as well.
Thank you, Simon. Tony, the floor is yours.
Thank you, Ria. Really appreciate taking the time to include me today. I know that with Simon and Nicola, you kind of can see exactly where they fit into this panel, and you might think, Intel, how does Intel fit into health and life sciences? Maybe AI makes sense, but the health and life sciences kind of angle doesn't seem to make sense. I'm actually a medical doctor and data scientist, and I'm the chief AI architect for health and life sciences at Intel. Where we fit in is actually kind of interesting, and I always kind of start with the story of Intel Inside, those little stickers that you saw maybe 20 years ago, and we had kind of the marketing campaign to let you know that our hardware was kind of in these laptops and desktops that you see. You might not think of it, but if you walk into any hospital today, yes, you'll see those laptops and tablets and desktops and servers and things like that. But even those MRIs, those CT scanners, the ultrasounds, they're actually computers, and they actually have our hardware or some sort of computer hardware in there. So I'm kind of blessed that what I get to do is I get to work with companies that are making those devices and try to make them, these AI algorithms run faster on our hardware and try to optimize kind of the whole pipeline. So I'm a bit like a kid in a candy store, or maybe a kid that gets to peek at the presents before Christmas. I get to see what's next and what companies are doing. And so that's what I'm going to talk about. I love the term beyond the buzz, because I really have seen it go beyond just academic an academic nicety to something that's actually being used in industry today. So when I started looking at this, I was wondering about FDA clearance, and I know that Simon had talked about this as well. So initially the question was, how are these things regulated? And they're regulated just like every other device that you see out there. There's a 510 clearance that most of the companies are going through. And so they're basing them off of the usual computer-assisted diagnosis that we've had for decades now. And really, this is just kind of the next wave in that these AI algorithms. They're the things that help you with the triaging and the workflow optimization, if you will. When I saw this about 2 years ago, maybe 2-3 years ago, there was maybe a few dozen algorithms or solutions that were 510K cleared. I think maybe last year it was somewhere around 90, something like that. And I believe there's probably at least over 100 now. One of the places that you can check if you want to see what sorts of algorithms are out there is going to the American College of Radiology. They have a website from their Data Science Institute, which is a new institute that they developed, I think, mostly because of all of this explosion of this particularly in the radiology field. And they actually have a website where you can go through and you can look at all the companies and all of the solutions. So this is a great way to look at beyond the buzz as to what is actually has been approved and what's actually being used today. This is one I want to highlight, and I just have a few minutes, so I could spend hours talking about all the companies that we've worked with. But I like this one because it really shows you something actually in practice. This was a portable X-ray machine that is being used in the hospital today. It was cleared. It's a GE Healthcare Optima XR 240 AMX, and it does pneumothorax detection. So I always want to say we saw this at we actually saw a few of these machines at the RSNA conference, and I think there was actually a little Intel Inside sticker on it that maybe or maybe not I had come by and just added to it. But the nice thing about this, and kind of to allay people's fears as to exactly what this means, this was really for triaging. And so the idea here was take yourself back to how the workflow happens in a hospital. Usually if you're in an ICU, you'll have a standing order to have an X-ray, a chest X-ray each night or each day. And so it's usually a routine thing, meaning that the technician is going to roll through the ICU and just do X-ray, 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 X-ray. And it might sit in like a queue waiting for some provider, a radiologist or the ICU staff, to take a look at it and make sure that the patient's doing all right. There's no pneumonia, there's no acute conditions kind of going on. And since it's routine, that could take hours. It's just when people get around to it. And so what they said was, let's try to take some of these AI algorithms, and this one was actually 3 distinct AI algorithms that we had helped them optimize. They created the algorithms. We just made them run faster on the Intel CPU that's actually in this device. So right on the device, they were able to actually have an algorithm that detected a collapsed lung, a pneumothorax. Obviously, if you have a collapsed lung, you want a provider to get in there as quickly as possible. And so what this allowed them to do was just to adequately triage. The X-ray would be taken within, I believe it was less than a second. You would get a initial reading or initial alert from the machine that said, hey, I think a human being needs to get into the loop here because we think there's a pneumothorax here. And so this is really amazing because when you hear about the buzz, here it is. It's actually in hospitals today, and it's actually working. These have been the low-hanging fruit that I've seen, particularly all the radiology specialties, anything that to do with images are really using these. Speaking of images, anything with digital pathology, anything with drug discovery, anything with genomics, they all really fall into those sorts of categories as well. So this has just really exploded, and many of the algorithms that you'll see that have already been 510K cleared rely on something like this, where it's an image, and the AI is really just helping you optimize workflows or triage patients appropriately. But it's all as we heard from Nicola, it's all not just images. NLP or natural language processing is huge as well, and is equally important. Particularly as we saw with Simon, just these workflows and these EHRs. This is lots of text data that we have to go through, and it's something that if it's either the computer goes through it and helps us to sift the actionable information out of it, or we have a human being that literally has to read something. I wanted to do this one just because it was one that I was also involved. I'm actually also involved in now, and relating to COVID. We actually there was a data set that was released through a contest called Kaggle. It was a data set from the White House that had released on all of these scientific articles about COVID, about SARS, about MERS, about viruses in general, and pandemics in general. Our group was tasked with, we're always encouraged in Intel to do additional things that excite us. And so when the pandemic came out, they said, hey, we'd love for you to take some time to do some fun things that, are interesting to you and you think that are meaningful. If there's anything you want to do with COVID, we'd love to kind of either officially or unofficially support you. So this is one that my bosses were really happy about. We actually took a model. There's a whole new generation of NLP models called BERT, just like the cartoon, or just like the Muppets character or the Sesame Street character. It's actually a backronym for bidirectional encoder representation from transformers. Transformers are also just like the robots in disguise. So this is always a fun field to deal with these researchers. But short of it is that you can take a very long, complicated text and you can actually train the model so that if a human being asks a question about this text, it can actually find the place and the answer within the text. And so you can see how this would be important if you're looking through, let's say, trying to do vaccine discovery or trying to do clinical trials, and you've got all of this text that you have to go through and trying to find out some questions about whether the efficacy of the drug, what the side effects were, all of these things that maybe or maybe not are in sort of a template to follow. Maybe they're just free text like this. And so things like this really help to optimize that workflow. I want to end with this one, just talking about if you're looking for more information, Intel, this is kind of our website on artificial intelligence. I've got dozens of articles up here that our group has done. This is one that we were highlighting the RSNA, the Radiological Society of North America conference that just happened in December. Hopefully we'll be able to get all together again this December and not have to do it virtually. But what was amazing about this, $580 million in AI-focused just imaging startup research. When I first came to RSNA, there wasn't any mention of AI. This was like 5 years ago. Last year, there was a small booths, but there were in everybody's booth. This year I went and I said, oh, where's the little booth that I need to be in? And they said, oh, we actually have another hall that is just for AI in radiology. It was amazing. They had not just the normal machines that they were doing and the normal things that they were doing, but AI got an entire kind of section, an entire hall that was focused just on it. So this is just amazing that in just this 5-year period, we've gone from seeing nothing to seeing it be in actual products and being really meaningful. So I'm going to end it with that, and I look forward to the panel talking more into it.
Thank you so much, and thank you all. Fantastic to see the wide-ranging use cases and applications of AI. Nicola, you talked about the challenge around scaled quality care. How can AI be most effective in scaling care to meet the needs of more people or unique populations?
Thank you, Ria. It's a great question. If I think about the challenges in healthcare and mental health care for providers, the amount of burden that's on their shoulders. In mental health care specifically, half of therapists still are until recently using pen and paper. If you talk about being able to think about insights collectively and share as a community, And there's a long history for that, and part mental health not being included in meaningful use and elements of that. But if we think about how can AI really help and really accelerate and add the most value, I think first about this administrative burden. How do we, and it's not just tech automating, it's understanding what's in the 50% of time that doctors spend on the desktop, right? Looking at that administrative burden and understanding what's meaningful, where do we streamline based on behaviors? Secondly is looking at insights. And insights are twofold. I think Simon and I both talked about there's a lot of passive data and interesting data you can stitch together with technology and learning. There's a lot of opportunity when you think about making conversations digital, whether that's recording voice or whether it's looking at chats, and really understanding what is the dynamic in that conversation, what is the use case, what are the patterns. There's also opportunity for clinicians to talk to each other and collaborate. And I think technology can really help surface insights from all these different data sources and synthesize what does a journey look like for this type of population? Where does it intersect with this other one? And gather that feedback from members to understand what's really most effective and leads to meaningful results. So I think if we think about these populations that perhaps are suffering the most, I think, in our system during this COVID period, we've seen like a 94% increase last week versus pre-COVID on folks just using coaching, 133% increase in folks using therapy versus not. What AI has really helped us do is understand what's happening in these increased sessions. We're able to identify, okay, here are the, folks are worried about layoffs, they're worried about relationships, they're worried about being overwhelmed. The AI really helps us understand what are the parts and themes of those conversations, and then apply them into real resources. We've released new content modules within our system, for example, clinically validated content. We've launched, there's a Ginger Roots page, just made some of that content available to the general public just by using our technology and insights to be able to understand the use cases of those struggling the most, and for example, in a time like this.
Thank you, Nicola. If I have to take one thing away from all the presentations and remarks today, is that AI is really starting to prove itself as a game changer in how things are done in the healthcare setting, from improving efficiencies to care. To what extent are clinicians worried about AI replacing their jobs? Simon? Would you like to comment on that?
I can only speak for what we do in our domain of chronic care management and virtual care. But our experience is they're embracing it. In fact, they want more of it faster. And I think it actually ties back to much of what Nicola was mentioning, in that there's already clinician shortage. We have nurses or physicians in the country. And for chronic care in particular, the promised land is actually to have more continuously available, when it's needed, care and capacity. And so it presents one big resource optimization problem. Is if I suddenly have eyes and ears on thousands of patients at any one time instead of the few who are in my clinic today or hospital, that means you need to be you need the help of machine learning and computational techniques to prioritize those patients and really match the available demand to available capacity, and to de-average the sort of protocols about how often you should see someone, and which tend to be quite standardized today. So our experience as our clinicians are really sort of have a great thirst for it. I think this ultimately allows more automation. It allows personalization of protocols and care plans. and allows clinicians to be operating top of license. That's really the goal here. And so our experience is that it's very, very positive, and it's still very early days, and we're just scratching the surface of what's possible. But there's certain applications in healthcare that are truly augmentations to human capabilities that humans cannot, are not naturally good at. For instance, and Nicola touched on this as well. We, on a heart failure patient, on any given day, getting about 100 data features. You can't have a clinician look at those. But presenting about 5, right? And so it's sort of an example of a nice, I think, symbiotic relationship between human and machine in this case.
Thank you, Simon. Nicola, would you like to add something?
Yeah, couldn't agree more with Simon's points, and think that we're seeing the same thing in mental health. I thought of an interesting analogy. In these recent times, we talk a lot about temperature check. I got a really good kick out of Tony's Bert with the temperature check here. AI in many ways can be the temperature check for clinicians that measures all these, long tail of interactions that Simon and I are measuring that they just don't have. So within our health system, we've seen the same reaction, where the ability that AI allows to give just that temperature check so that that clinician can go and get their information and then quickly input and get that feedback loop that just doesn't exist in brick and mortar care with a physical temperature. So I think that's a huge advantage. We're basically giving them AI is giving them a virtual temperature check.
I think can I add something here? In what we do, there's a real danger in inundating the clinical teams with too much information. And, it's essential to sort of manage the classic problem of sensitivity and specificity in models, as to avoid, false positives in effect, and driving unnecessary care or unnecessary burden on the clinical teams as well. And this is so there's a lot of promise, and at the same time, it does raise the bar for this sort of technology.
Thank you both. Tony, did you have any thoughts on this?
So I was thinking about the scaling issue, and especially what Simon said with trying to get the relevant data, the relevant actionable data back. I was just actually talking to some telemedicine providers the other day, and one of them was seeing I think it was from patients going home and having to do patient monitoring at home, just checking up with 1,900 patients in a single day. There's no way that even a large medical center can really handle that sort of scaling. And so they came up with it doesn't have to be like the most sophisticated AI algorithm, but they came up with just something that would allow them to have the patients get surveyed each day. It would be automated, and it would give them a green light, yellow light, red light sort of thing that would be passed back to the providers and say, here are the ones you probably don't need. We can wait until maybe tomorrow or the next day. Here are the ones you have to contact right away. And without that, it's just a deluge of data that there's really no way to get through. I believe that Cleveland Clinic had, I think, 60,000 telehealth visits in March compared to like 3,400 the March before. So we're getting to the stage where the numbers are not just 2x or 3x or even 4x; they're like 10x. And as Simon said, with the radiologists, it's not just being replaced. It's the fact that we don't have enough in the pipeline now to keep up with the amount of work that's coming in. So something's going to break somewhere if we don't find a way to make their lives easier.
Thank you. Very helpful insights. One of the hot button issues when we talk about AI and health is privacy. Can you talk about how privacy is being addressed in the deployment of AI to the healthcare sector? Tony. How about we start with you?
Absolutely, absolutely. So there's many ways to talk about that, and one of the interesting things that we've been working on, and many others have, is a concept called Federated Learning. And it's one of these things you think, oh, is it the federal government? It's not anything like that. The idea is you're actually allowing the data to just live wherever it lives. The data actually never leaves the hospital, never leaves the site. You're actually sending the training or the compute to the hospital or to wherever the data happens to be. What this helps you to do is a few things in terms of bias, or in terms of trying to look at issues with bias in models. Maybe models are trained on certain populations. More robust models, more fair models might be better addressed if you're able to get a wider population to train off of. This allows you to do that and to keep the privacy enabled as well. And so you're actually able to kind of get the best of both worlds, where you're able to train a very robust model that, hopefully has as few of bias as possible, but not really exposing patient data. And we've seen this even if it weren't for the fact that there's HIPAA and there's, all sorts of state and federal regulations around this data, the sheer volume of the data, precludes it from moving, from one place to the other without somebody literally taking a hard drive and, mailing it to someone else. So I see Federated as kind of a really nice way of handling a lot of the issues that we talk about with scale, with bias, and with privacy.
Thank you, Tony. And with that, we will now open up the floor for audience questions. If you haven't already, go ahead and submit your question for our speakers. Again, you can do this by clicking on the icon with the speech bubble in the toolbar at the bottom of your screen. We'll try to get to as many questions as possible today.
Go.
No.
All right, so our first question is, how can AI help to reduce some of the back-end burden in healthcare? Nicola, how about we start with you?
Sure, Ria. Just quickly, I think AI can be helpful reducing administrative burden, supporting quality to higher levels, both with measurement as well as feedback loops and decision making. We know today there's a tremendous burden placed on the shoulders of providers, and I think there's a tremendous incentive to lift that burden off their shoulders and get them back to doing the practice that they love.
Simon, any quick thoughts from you?
Yeah, I might be being a bit liberal with the definition of backend, but I think it might suffice. One of the favorite sort of use cases that we're excited about is the identification of very individualized care gaps that, sometimes might fall under sort of notion of population health, but getting that very individualized, that go beyond the obvious things of, who needs their flu shot or who hasn't had it, and getting those communications out, but to the level of, finding, let's say, gaps in care where people are below guideline-directed medical therapy. So, for instance, take a heart failure patient might typically be required to be on or benefit from, a combination of 5 different medications. Each medication has a different optimal titration for who they are and where they are in the progression of their disease. Today, those are very tedious processes to go and find those gaps to GDMT, and to the point where I think we know that often just doesn't happen. But this is where I think AI and machine learning specifically, and even good old automation, can do a lot of that sort of clinical grunt work to surface up these gaps in care that are very individualized and get them into workflow. Otherwise they might be missed altogether and or just take too much administrative or clinical time to surface them.
Thank you, Simon and Nicola. Tony, any thoughts from you?
Yeah, I like what Simon said about the grunt work. I guess I would define back-end burden as anything that doesn't involve the actual patient care. So things like CPT or billing codes from free text reports. It's a huge cost to the system. Places like 3M, EMScribe, a lot of the EHR and EMR companies are doing this already. I talked about some the BERT NLP models doing synopsis of provider-patient interaction, so you can get kind of a template for the note of the interaction that you just had. And then finally, for radiology, the workloads are just growing faster than literally going faster than the number of radiologists that are being trained. So you saw things like the triage system with the portable chest X-ray for pneumothorax. There was a Stanford radiologist who said something to the effect of, AI won't replace radiologists, but radiologists who use AI will replace radiologists who don't. And that's simply because they'll be more productive and they'll be able to basically handle this back-end burden.
Thank you for your quick insights there, Tony. Looks like that's all the time we have for today. We apologize for the technical difficulties we experienced earlier in the session. I want to thank all of our speakers for joining us for this great session today. If you would like to learn more about AI and healthcare solutions, you can check out the AI and Health Standard, and you'll find that link to the far right of your screen. We hope you'll join us for the other panel discussions and working group meetings during the Technology and Standards Spring Forum, which runs through Thursday, May 14th. You can find a full schedule of forum events at cta.tech/TS Spring Forum. If you would like to join our Artificial Intelligence Committee meeting, that meeting starts right now, and you can find links to join those meetings in the resources area on the right side of your screen. Thank you again.